the today's topic is an interesting topic, obstructive sleep apnea and overview. And to helm today's discussion, we have with us Dr. Shalabh Rastogi. He is a senior consultant and head of the Department of ENT at Tata Motors Hospital, Jamshedpur, Jharkhand. And this is a 404 bedded hospital, which is a DNB accredited hospital. Dr. Shalabh has been over there for the last 7 years and has been supervising DNB trainees over there in terms of surgical training and supervising their thesis. And he is a graduate and postgraduate from Delhi, graduate from Maulana Azad, and postgraduate from my institution, University College of Medical Sciences. And a good student. He used to be a good student, and now he is an excellent teacher. Has received a number of awards in excellence from his hospital, and is a member of various committees at the hospital, and is involved in the extracurricular activities over there as well. And so he'll be talking about obstructive sleep apnea today. So Dr. Shalabh, welcome.
Thank you, Dr. Nilima. And I thanks to National Board for giving me an opportunity to talk about the obstructive sleep apnea, which is kind of hot topic in current scenarios. So welcome to all the students and good evening. Let's see that what knowledge advancement I can give you in next 1 hour. So the today's topic is obstructive sleep apnea. I'll try to touch each and every aspect of that thing, not going into too much details, but try to give you a perspective view of obstructive sleep apnea. So this is my hospital from Jamshedpur. It's a 404 bedded hospital, which is accredited for DNB teaching. Now, obstructive sleep apnea is an important topic for you people because you will get lots of question in obstructive sleep apnea. In the last theory examination also, you'll get 2 to 3 questions from obstructive sleep apnea. So we'll be dealing this topic on following headings. My first headings will be to understand the disease. The second part of my presentation is to how will you clinically evaluate patients of obstructive sleep apnea. And the last but not the least is how will you manage, what are the treatment you can offer to such patients. So starting with definition, obstructive sleep apnea is a type of sleep-related breathing disorder which is characterized by repetitive episodes of complete or partial collapse of upper airway, resulting into complete or reduction in airflow. So, which leads to arousal and hypoxia. So there are 3 important components of this thing. One is there is an obstruction of upper airway. Second is it happens during sleep time only. And third, it leads to hypoxia and arousal from sleep and resulting into hypoxic repeated hypoxia. So why it is important? Historically, it is called Pickwickian syndrome. It has taken its name from a novel from Charles Durkheim in 1836, in which the name of the boy is Joe the fat guy, in which the character is having obese personality with hypoventilation, and he keeps on dozing in a daytime. So from that time onwards, it was called as a Pickwickian syndrome, and initially the prevalence stated was around 2%. But in 1950 to 1980, lots of work has been done to understand the pathophysiology of this disease, and it got its name as obstructive sleep apnea. So in that time only, we got the treatment, medical treatment in the form of CPAP. We got the surgical treatment in the form of UPP3, and thereafter there was a period of silence, and later in last 10 to 15 years it has regained its basically importance, and the prevalence is also increases, maybe because it is closely related with the obesity, and or it might be because of the uniformity in the criteria all over the world. So in 2007, WHO has estimated around 100 millions of people who are affected with obstructive sleep apnea. But in 2019, Benzafield in Lancet Respiratory Medicine has estimated around 1 billion population to have obstructive sleep apnea. Out of 7 billion population of world, every seventh person is having features of obstructive sleep apnea. So various study has shown the prevalence in men around 22%, in women around 17%. In India, it is estimated to be around somewhere less than 10%. In Indian efforts for sleep medicine started in 2012 in an organized manner, in which an association was formed named as ISA, Indian Association of Sleep Surgeon for Sleep Apnea, and maybe in few years they will come out with a dedicated fellowship for the sleep apnea surgeries. So that was a background. Now, what happens in obstructive sleep apnea? So this is the normal airway, and which start from nose, nasopharynx, oropharynx, and then larynx. During daytime, it is open, but during night time, somehow it get repeatedly closed, so that there is a choking of patient, and patient repeatedly get awakened. So who all are having tendency to have obstructive sleep apnea? What are the risk factors? Among the risk factors, the known are the older age people. It's more prevalent in patients above 50. Then the male gender, in female it is more common during pregnancy. The patients who have who have a tendency to deposit fat in the central axis, then it is very closely related to obesity. Patient with short neck, and in which the circumference of neck is greater than 40 centimeter. A patient who are having orofacial anomalies, then the Down syndrome, and the patient, it is related to their genetic predisposition also, and it's more common in patients who are intoxicated with narcotic drugs and alcohol or any sedatives. So what happens, what is a pathophysiology for this thing? The airway is a mix of collapsible and non-collapsible segment. The nose and the larynx are non-collapsible, whereas the pharynx is a muscular tube. It's a collapsible segment. So there is a balance between the dilator and the collapsing force, which are acting throughout day. What are the dilator force mainly acting? It's a tone of pharyngeal and tongue muscle and the tug from the lower airway. And what are the collapsing forces? It's the resistance created in the airway, of which 50% is contributed by nose, and there's an intraluminal pressure which decreases when there's a more negative intrathoracic pressure is created. Then the soft tissue, or weight of the soft tissue, and the sucking effect of the soft tissue leading to collapse. Now, these things, there's a delicate balance between the dilator and the collapsing forces, but this force changes during sleep state. So what happens during sleep state is there's a decrease in muscle tone, which causes a decrease in size of airway. As you all know, the size of airway is greatly responsible for increase in resistance as per the Poiseuille's law, in which the resistance is increased by the if the radius is increased, and it is related to the fourth power of the radius. So when the muscle tone decreases, size also decrease and it cause increase in resistance. Simultaneously, the weight of soft tissue. Now the patient is sleeping in the supine position, the weight of neck and the tissue around the pharynx also cause reduction in the size, as well as it increase the extraluminal pressure. To both these affect cause great increase in resistance, and to tide over that resistance, the thoracic cavity has to uh, exert more pressure, and it creates more negative intrathoracic pressure, which leads to the decrease in intraluminal pressure. Now, according to the Starling's register model of upper airway, it says that if a tube is made up of collapsible and non-collapsible segment, and if the resistance at the non-collapsible end increases, then the collapsing segment may collapse because of negative pressure. The best example is a straw. If you low quality straw, if you try to suck the fluid from the straw, sometimes it gets blocked, and even if you create more negative pressure, it's not going to open up. You have to give a positive pressure to open that thing. When this things is added by the increased velocity by negative intrathoracic pressure and decreased pressure, it causes choking off or collapse of the pharyngeal segment. So what happens after that? The patient, the oxygen saturation decreases, and which stimulates the chemoreceptors and which awakens the brain. Then patient awakes and the muscle tone increases and he clears up the throat and oxygen again started flowing. Air exchange happen and patient then goes into sleep. And this cycle again keeps on repeating every time in the night. So you can understand from this thing that how much disturbed sleep patient might be having when he's having repeated episodes of choking and repeated episodes of waking, and this goes on and on in a vicious circle. So what are the consequences of these things? The main consequences of obstructive sleep apnea are because of either the sleep fragmentation or the cause of hypoxia, which leads into endothelial dysfunction, inflammation, and increased oxidative stress to the body. All these things, the sleep fragmentation cause the neuropsychiatric problems, neurocognitive problems, and decreased sleep, altered disturbed sleep results into poor concentration, tendency to for accidents, the hypoxemia and the intrathoracic pressure thing cause increased sympathetic activity. And as I told you, endothelial dysfunction, which results into stroke, myocardial infarction, increased tendency for atherosclerosis, increased sympathetic tone, and all these things have multifactorial effect. So in endocrine, they may cause insulin resistance and precipitate diabetes mellitus. So in all, the effect of OSA leads to multiple affection of in the body. Hence, it is sometimes called as obstructive sleep apnea syndrome. So, what are the symptoms? It can be divided into daytime symptoms. When the patient is feeling fatigue, patient might be having headache. It's a daytime somnolence. It's a increased irritability, and sometimes patient falls asleep during routine activity when there is a small period of non-disturbance. And there are night symptoms like loud snoring, repeated cough, restlessness, choking, and frequent visit to washrooms. So Up till now, I told you the pathophysiology of the disease and why it happens, when it happens, how it affects the various functions of the body, and what symptoms it causes. Now, let us talk about if such patients comes to your OPD, or if such patients might be your relative, then how will you further investigate or further evaluate that patient? The patient might be coming you with the symptoms of snoring, excessive daytime sleepiness, or it might be a referral from your fellow physician. So, what history you should elicit? You should take all the nocturnal and daytime symptoms. You should ask both patient as well as bed partner for the evaluation of history, and especially for the bed partner for witness of episodes of apnea and labored breathing. You have to identify high-risk patients like uncontrolled diabetes mellitus, uncontrolled hypertension, or ischemic heart disease, because in such patient, this OSA might be fatal for them. So you have to segregate such patient and give them proper treatment. For the excessive daytime somnolence, there are various questionnaires which are available in literature. Uh, Two of them are quite common, and one is the Epworth Sleepiness Scale and other is the Stop Bank questionnaire. In the Epworth Sleepiness Scale, there are 8 conditions in which a patient has been asked to rate from 0 to 3 the amount of the chances of those or having a nap during activities like sitting and reading, watching television, lying down in the rest in afternoons, sitting and talking to someone, etc., etc. And if the score, the maximum score could be 24, but if the score is greater than 10, then patient is having excessive daytime sleepiness. The second questionnaire is top bank questionnaire, in which various risk factor has been described, and patient has to say yes or no for the for those high risk condition. And if he takes yes for 3 or more such high risk thing, then patient is having more prone for obstructive sleep apnea. So after history taking and one should look for the clinical evaluation of such obstructive apnea patients. So what are the main things one should look for? One should look for the obesity, the BMI greater than 30. One should look for the short neck. Then it is found that if the neck measures more than 40 centimeter, then there is a high tendency for such patients to go into sleep apnea. You should also look for the craniofacial anomalies. Then you should do a proper and detailed upper airway evaluation with the flexible nasopharyngoscope. You should look for the nose, palate, tonsil, lateral pharyngeal wall, tongue base, epiglottis. And you should do FOL in awake and supine position. So next time, whenever you do, most of you must be having access to the fiber optic laryngoscope. So next time, whenever you do a fiber optic laryngoscopy, just take a detailed note of all these things, and you can also do a Muller's maneuver, which is a negative of the Valsalva, in which the nose and throat, nostril and mouth are closed, and patient is asked to inspirate deeply. So it creates a negative pressure. Now, various classification are there for noting down the evaluation of the upper airway. One of them is the modified Mallampati classification. Mallampati classification is you must have seen in your PSC sheets, in which the anesthetist noted from grade 1 to 3. It is basically the based on the uvula length and the oropharyngeal structure you can see. So in grade 1, you can see whole of the uvula, you can see the tonsil also, you can see the posterior pharyngeal wall. In grade 2, you see only full of the soft palate arch, but partially the tonsil and partially length of the uvula. In the grade 3, you can see only the base of uvula. Later on, it has been modified and a fourth grade was added in which you cannot see the soft palate. You can only see the hard palate. So taking inspiration from this modified Mallampati classification, Friedman has given various categories for tongue position and tonsils. He said that during Mallampati classification, you protrude the tongue, which is not a physiological condition. So during sleep, one patient sleep with a mouth closed. So tongue should remain its neutral position. So he gave the classification by keeping the tongue position its neutral position, and it was graded as grade 1, 2, 3, 4, just like the modified Mallampati classification. And he also gave the tonsillar grading, in which the tonsillar grade 1 when tonsil is hidden behind the pillars, grade 2 when it can be seen just outside the pillars, grade 3 when significant portion of tonsil is coming out of the pillars but not meeting the midline, and grade 4 are called the kissing tonsils. On the basis of Friedman tongue position and tonsil grading, he gave a classification for proposing the treatment of such patients. So in stage 1, the favorable tongue position, the Friedman tongue position is in favorable condition. That is, it is grade 1 and grade 2. Tonsil size are quite high and BMI is less than 40. In such position, patient will be benefited by the UP3 procedure. In stage 2, when the tongue position is not that neither tongue nor tonsil are contributing to obstructive sleep apnea, or when there is grade 3, grade 4 tongue position and grade 3, grade 4 tonsil, both are contributing, then such patients have 50% chance of responding to UP3 procedure. In grade 3, when the tongue position is not favorable, that is grade 3 and grade 4, and the tonsil size is 0, 1, 2, and BMI is less than 40, then these patients are will not respond to the UP3 procedure, only the palatal procedure. You have to do something to the base of tongue also. And in grade 4, either you have a craniofacial anomaly or your BMI is greater than 40. These patients are not fit for the surgical corrections. So after your history and examination, you have a fair amount of confidence that you are dealing with the OSA patient. Then you have to label them with certain investigation that they are OSA patient. For that, you have to do physiological testing and anatomical testing. In anatomical testing, I told you just that you can do a fiber optic laryngoscopy by supine awake position and along with the Muller's maneuver. You can do a dynamic MRI, which is also called a sleep MRI or cine MRI. You can do a DICE, drug-induced sleep endoscopy. And if patient is having any nasal problem, then you can do a CTPNS, etc. In the physiological assessment, you have to do a polysomnography. In the current recommendation, before you take patient for any definitive management, are that you should, along with PSG, along with the polysomnography, you should do a dynamic MRI plus awake fiber optic laryngoscopy or a drug-induced sleep endoscopy. Coming to the polysomnography, this is considered as a gold standard technique for diagnosing OSA. It gives you certain indexes by which you can grade them, by which you can label them and then grade the severity of sleep apnea. So there are various levels of polysomnography. It can be done in the lab or it can be done at homes. According to that, it has been graded. And this time also, I think you got a question on level of polysomnography. So level 1 says that it should be done in a lab and all the parameters should be noted down. And it is attended by a sleep technologist. So that if during night, if during study, if any limb leads dislodged, then it can be corrected on site. In level 2, there is a comprehensive study with almost all the parameters, but it is not attended by a sleep technologist. In the level 3, the problem with level 1 and level 2 is that the patient has to go in a sleep lab and sleep there. So which may not be possible for every patient. Some patients are comfortable at home only. So if you are dealing with the OSA patient by history and examination, you are quite sure that you are dealing with the obstructive sleep apnea patient, then you can advise them home sleep based study also. So in this study, there are multiple channels, but may be less than the what in sleep lab, and it can be done at home. The main thing is you have to assess the cardiorespiratory parameters of the patient. Level 4 is single or dual parameter like oxygen saturation and airflow. And this type of polysomnography is not validated yet. So one should do either one or up to level 3. Now, there is another type of study in which the half night is used for polysomnography and half night is used for titration with CPAP machine. Such study is called split night study. So what are the parameters we monitor in polysomnography? We monitor EEG that will tell us the brainwave activity, which will suggest us the sleep stage. We monitor electromyography, which monitor the muscle activity. We put it over the masseter, we put it submentally, we put it on various limb, so that we can notice the bruxism and awakening of the patient. ECG, it monitors heart rate and arrhythmias. Electrooculography, it monitors the eye movement, which can differentiate between the REM and a non-REM state of sleep. Nasal cannula, which measures the inflow and outflow of air. Pulse oximetry, saturation. Thoracoabdominal belt, this gives the information about the respiratory effort. A microphone for snoring, body position limb movement sensors to measure the periodic limb movement, and video recording for entire sleep. That will tell us the amount the restlessness during the sleep. Now, there are various important definitions by which you should know. One is apnea. Apnea is described as a decrease in airflow greater than 90% of the time for at least 10 seconds, which results in awakening of the patient. Hypopnea is a reduction of air pressure by greater than 30% for at least 10 seconds, which results in desaturation of at least 3 to 4% and results into arousal. Now, another term is respiratory effort related arousal, which is commonly called as RERA. It is if there is a disturbance or the respiratory event which is not fitting into apnea and hypopnea, but results into awakening. Such events are called RERAs. Then another term is AHI. It's a number of apneas and hypopnea divided by total sleep time. So the main parameters which we monitor in polysomnography is AHI and RDI. RDI stands for Respiratory Disturbance Index. When we count RERAs also along with the AHI. So RDI is more sensitive than AHI. Now the report is given in 5 headings. First is the sleep architecture, and in which you get the information about how much time patients spend in each stage. The important thing is sleep efficiency. If it should be greater than 85 to validate the study. That means the patient slept effectively 85% of the time of the sleep recording. Otherwise, if sleep efficiency is less, then it gives a low false low measure of AHI. Second heading is respiratory summary. It tells you about the respiratory events. I just told you apnea, hypopnea, rera. It also tells you the total time spent with saturation less than 90% and the lowest oxygen saturation which goes during the night time. Third is the periodic limb movement. In adult, the example is restless syndrome. In adult, if awakening, if there is greater than 15 movement per hour, it is considered to be significant. In children, if it is greater than 5, then it is considered to be significant. The fourth heading will tell you about the sleep fragmentation or the number of arousals during the night time. And each arousal is given a cause for it. Either it could be spontaneous or it could be respiratory because of apnea, hypopnea, or it could be because of periodic limb movement. So this will tell you about the cause of disturbed sleep, which results into excessive daytime somnolence. The fifth heading is cardiac analysis. It tells you about the arrhythmias and the heart rate and the heart block during sleep. So you can see this thing that there is a reduced airflow and there is no effort, so it is central apnea. There is a reduced airflow, but efforts are there, so it's a obstructive. It's a having the both the features, so it's a mix. In the hypopnea, the ventilatory efforts are there and airflow is reduced. It's not absent. So it is called hypopnea. And when the respiratory effort is there and it results into awakening, it is called RERAS, which signifies upper airway resistance syndrome. So according to AHI or RDI, the degree of OSA has been classified as less than 5 is considered per hour considered to be normal, 5 to 15 is considered to be mild, and 15 to 30 is considered to be moderate. Greater than 30 is considered to be severe. Now, once you have the polysomnography report, the next step will be to take patient for DICE examination. So what is DICE? It is a flexible nasolaryngopharyngoscopy during the induced sleep. The main feature of DICE are it should be done in operation theater. The operation room should be kept dark and the environment should be made conducive to make patients sleep. Small sedative drugs are given by the trained anesthetist, and sedation cause respiratory depression also. So all the things to resuscitate the patient during that time should be available, which includes oxygen, airway or endotracheal tube, suction. Another important thing is monitoring of the brain activity. If it is available, one should always go for it. It's called BIS monitoring or bispectral index monitoring. You should always keep BIS between 50 to 70, not less than 50 for the DICE. Now, what are the aims for the DICE? Why do we do DICE? So we get to see the three-dimensional view of all the structures. We can see the level of collapse. We can see the degree of collapse. We can plan our surgical treatment. We can evaluate the failure of the surgery. It can be therapeutic also. We can do head turning. We can do S-march maneuver, which is called the jaw protrusion. Such type of therapeutic or interventional DICE are called interventional DICE. The various advantage, what is the advantage of DICE? Basically, we get to see all the structures in front of us, how they behave during the night time. So it mimics the dynamics of airway during sleep. Now, what are the disadvantages? There are various disadvantages for the DICE. Basically, it's not a natural sleep. So it is induced by the drug, and all the anesthetic drugs may cause loss of tone and reflexes. So it may give an altered response. Another thing is there are various variables in the DICE, like nasal congestion, whether you give nasal anesthesia, what are the drugs used, at what rate, what is the protocol, and which stage of the sleep you are monitoring them. It's a subjective test, so inter-observer variability is there. There's a question mark on the reproducibility and the reliability. Obviously, it is costly and as it needs infrastructure and expertise. And most important thing is it requires general anesthesia fitness and informed consent. It is a potentially fatal procedure, so you should explain these things to the patient. And if patient listen to all those things, he may not be ready for the procedure. So what are the drugs used for DICE? These are midazolam, propofol, which is considered to be the drug of choice for DICE. Now, dexmedetomidine is taking over propofol, and because of its various advantages. Now, every center should develop its own protocol. They should define the protocol very clearly that we'll give this drug at this rate and we'll monitor the patient to such thing, and all those parameters should be clearly noted down. After that, after the procedure, there should be the strict monitoring of patient. Patient may be discharged on the same day. Now, there is another term called advanced DICE. When I told you interventional DICE, another thing is advanced DICE. This is the DICE along with polysomnography. After DICE, the recordings are measured by vote classification, which basically which basically tell us at what area the obstruction is there. It stands for velum, oropharyngeal and lateral pharyngeal wall, tongue base, and epiglottis. Now, the findings are noted down in this this chart, which has a various column which tells about the degree of obstruction, which is measured as 0, 1, and 2. 0 is no obstruction, 1 is less than 50, between 50 to 75, and 2 is complete obstruction, that is greater than 75. And other column tells us about the configuration, which is the anteroposterior dimension reduction. It's a lateral collapse or a concentric collapse. So velum will have all the three types of collapse. Oropharynx will have only the lateral collapse. Tongue base have anteroposterior collapse only, and epiglottis may have anteroposterior and lateral collapse. So if I write V2C O2L T2 E2 AP, it makes more sense for the other person to understand what are the findings of my DICE. It says that velum is complete collapse with concentric, oropharynx have a complete collapse with a lateral collapse, tongue base has a complete collapse, epiglottis has complete anteroposterior collapse. It's a very, very dangerous situation, but hypothetical situation, but such patients are very difficult to treat. Now, if the patient is not GA fit or patient do not want to undergo DICE procedure, then what is the alternate? The alternate is dynamic MRI. It is also called a cine MRI or sleep MRI. What we do is we ask the patient to come after night meal in a very loose clothes so that he can sleep comfortably. He was made to lie in a gantry of MRI, and the temperature as well as other things are made in such a way that patient falls into sleep. So when the patient sleep, we start the MRI, and MRI sections are taken into axial and sagittal section. The report are made by mixing the 1 second clips, and it gives a short video type of reporting. So that short video you can see in the axial section, and you can see in a sagittal section. So during axial, you can see the level of collapse, during sagittal and the degree of collapse, and then during sagittal, you can see the number of or the multiple collapse, what all sides are contributing to the collapse. Now, this is a very reliable and reproducible thing, and it is measured objectively. So, but the only disadvantage of dynamic MRI is sometimes patients are unable to sleep in the high noise environment of MRI. So after DISE or dynamic MRI, you get to know the various level of obstruction. So now there is a concept of static and dynamic obstruction. The static obstruction are there, which is present always. It can be nasal congestion, nasal polyp, deviated septum, infinite hypertrophy, tonsils, adenoids. Now, other thing is dynamic, which is not present during the awake state, but present only during the sleep phase. So these are from the palate, oropharynx, tongue base, and epiglottis. Now, after all the assessment, you have to manage such patients. So the most important thing is you have to talk with your patient and tell them what is the problem and why you should consider this problem as a serious problem and what all things we can do for you. Since none of the treatment is 100%, so counseling is most important thing. So that patient cooperates and understand the severity as well as the amount of benefit which can be given by the various management, either it's a medical or any other. So a tailor-made treatment for patient should be made according to the disease factor, patient factor, and the surgeon's factor. The various options for management are medical management that may be either in the form of positional therapy, lifestyle modification, weight reduction, CPAP, or it might be in the form of appliances, or it might be in the form of surgical management. So what are the medical management? The most important management is lifestyle modification, weight reduction, exercise, regular exercise, sleep hygiene. Whatever type of management you offer to a patient, these things remain common in each and every type of management. Either you do a medical management purely, or you do give dental appliances, or you treat the patient surgically. These things should always be part of your program or treatment plan. One should limit caffeine, alcohol, narcotics, drug, and smoking. There are certain exercises which are prescribed for the reinforcing oropharyngeal musculature. This type of therapy is called myofascial therapy. A word about positional therapy. There are certain patients who snores or who faces apneas during supine position. But when patient sleep in a lateral or a prone position, they do not face any apnea. So such patients are good candidate for positional therapy in which you avoid patient to lay supine. That can either be done by special pajamas, special vest which have a cushion at the back so that patient, or you can, there are special pillows, wedge shaped pillows in which patient lay only in the lateral position. Second type of therapy in medical management is CPAP. It is still considered to be the treatment of choice for OSA, and one should always initially go for this thing. The long-term compliance is only 40%. What it does is when the we know that airway collapses after the intraluminal pressure goes below a critical pressure. So what it does is it creates a air stent and give a pressure. So above the critical pressure, critical collapsing pressure, so that air way should be maintained. What are the adverse effects of this CPAP? The various adverse effects are nasal congestion, rhinosinusitis, nasal irritation, nosebleed, poor compliance due to discomfort. It's very cumbersome for the patient to carry out CPAP machine wherever he wants to go. So till the time he use CPAP, he is okay with sleep. But the moment he take out the sleep app, patient again faces problem. Now, the second type of management is various devices. There are various devices available in over the counter as well as in a special orthodontic treatment. These are the nasal valve dilators, the mandibular advancement splints, and tongue holding devices. These there is special niche for all these devices. Certain patients in which if a tongue is protruded or a jaw is protruded and patient get relief from the symptoms, then we should definitely go for such type of devices. But these are difficult to use, and patient long-term use will result in dental problem and especially the TMJ. Coming to the surgical management, which is especially for the ENT surgeons, and the only thing is we as ENT surgeons are the only surgeons who can cure the obstructive sleep apnea. Rest of the medicines can only control that thing. But if we take out the obstruction in the path of airway, then we can cure that patient from obstructive sleep apnea. So what are the various surgeries? The various surgeries are the nasal surgery. We all know septoplasty and turbinate reduction. Another thing is hypertrophic tonsils. If the patient is having hypertrophic tonsil and adenoids, we can do adenotonsillectomy. And in one study, it has been postulated that around 50% of the patients of obstructive sleep apnea, if we simply do tonsil and adenoid surgery, they are the quality of life improves in 50% of the patient. Now, next thing is the palatal procedures. There are various palatal procedures described for obstructive sleep apnea. The classical being the uvulopalatopharyngoplasty, which was the initial palate procedure. After that, there are anterior palatoplasty technique in which the palate is shortened and anteroposterior dimensions is increased. If there is a lateral collapse, then the lateral pharyngoplasty techniques are available. The main four techniques which are available are relocation, expansion, sphincter palatoplasty by Woodson, barb pharyngoplasty, and a zeta pharyngoplasty, zeta palatoplasty. And other are palatal implants. So before understanding the palatal surgery, you can get a questions on palatal surgery also. So before understanding the palatal surgery, we should know that the soft palate is made up of 5 muscles: the the musculus uvulae, the palatoglossus, palatopharyngeus, which is the main muscle, which is the culprit muscle for obstructive sleep apnea. And superiorly, we have tensor palati and the levator palati. So all the treatment are focused to decrease the strength of palatopharyngeus and relocate it anteriorly. So what does a classical pharyngopalato-palatoplasty principle was? The principle was to reduce a enlarged soft palate, and the anterior arch and the posterior arch along with the pillars, they are sewing together. So after tonsillectomy, you take out the extra tissue of the soft palate and stitch all these things together. But it can only increase the anteroposterior dimension. So other various anteroposterior dimension procedures are uvulopalatal flap, in which we make a rhomboid incision and then stitch it over, and it's a reversible advantage is it's a reversible procedure, and if patient have velopharyngeal insufficiency, we can reverse this procedure. Other are the capsule cautery base or the radiofrequency base anterior palatoplasty, in which you take out the strip of mucosa and submucosal tissue and stitch it together so that soft palate shortens and it comes anteriorly. Now the various the lateral pharyngeal wall, if lateral pharyngeal wall is the culprit for obstruction, then the various procedures available are relocation pharyngoplasty, in which after tonsillectomy, the posterior palatoglossus muscle is sewn to uh, anterior pillar. Then the expansion sphincter paryngoplasty, in which the palatopharyngeus muscle is cut and stitched to the humulus of the pterygoid. So it comes anteriorly, and there is a lateral expansion in the dimension of the oropharynx. The third is a barb repositioning pharyngoplasty. It is done with a barb suture, which does not require suturing. It can only go in a one direction. So the 8-point suturing technique is described, in which the palatopharyngeus is taken to uh, raphe, pterygopalatine raphe, so that the lateral pharyngeal wall expand, and there's a marked increase in anteroposterior, decrease in anteroposterior dimension as well as lateral dimension. The fourth is a zeta pharyngoplasty. It is prescribed for either a concentric collapse or a patient with a failed UPP. So in this procedure, you take out the muscles, mucosa of soft palate, and you open it like a book, and then stitch this uvula over this thing. So both flaps opens up and creates a large space for the air. Now, various implants are available in the market, but these are not very fruitful and can only be used to stiffen the soft palate. What it does is, these are the absorbable implants. The 3 implants should be placed, one in the midline and one 5 millimeter paramedian position. So during after their absorption during 6 months, it causes fibrosis and absorptions, stiffening of the soft palate. Now the tongue, if tongue is the culprit, tongue base is the culprit, then various tongue procedures which are available are genoglossal advancement, hyoid suspension, either with the thyroid cartilage or with the mandible, or tongue-based radiofrequency, or the endoscopic partial midline glossectomy. I will basically tell you only the principles. If tongue falls is the cause of obstruction, then you, along with the genioglossus, along with the genial tubercle, you take it out on the anterior margin of the anterior table of the mandible, so that genioglossus is advanced and there is an opening of the posterior airway. In this manner, you do osteotomy in this manner, and along with the genial tubercle, you fix it to the anterior table of the mandible. Now, tongue fall can also be reduced if we fix hyoid either with the mandible with a suture, or we can bring it down and stitch it with the thyroid cartilage. During bringing it down, it basically opens up the airway, as well as it will not fall. Now, radio frequency reduction of the tongue base, we create multiple lesions in the base of tongue by the radio frequency, and once it gets fibrous, the tongue base reduces in size. Similarly, tongue base can also be reduced if we take out the rhomboid portion from the midline. We know that the lingual nerve and the hypoglossal nerve and the lingual artery are in the periphery of the tongue, and the midline is basically free from any neurovascular bundle. So we can take out a tissue around the midline. We can go up to 1 centimeter from midline and take out the mucosa, submucosa and part of muscle and stitch it in the midline. We can also reduce the tongue base, especially the lingual tonsil, with the radio frequency. Now, for the epiglottis, we can do epiglottopexy, in which we suture the epiglottis with a base tongue, or we can remove the extra portion of the epiglottis, which is called supraglottoplasty. These procedure can be done for the laryngomalacia patients also. So, the last but not the least is a skeleton surgery done by the maxillofacial friends. And in this, basically, they open up the posterior airway by advancing the maxilla as well as the mandible and fix it in new position. Now, all these surgeries gives a result in expert hand up to 40 to 80%. So there is a wide variety according to expertise. So hence, and these surgeries are recently being evolved. Less than 20 years are their total age. So we are still in a developing phase. So hopefully, new and better method may be coming with time. One of the good method is transoral robotic surgery. By this, you do a partial glossectomy. In this, you use a Da Vinci robot, which have 4 arms. 2 of them are used as a dissector, one as a cautery, and one is loaded with a high definition camera. The surgeon sits on the console, and the assistant sits near the patient, and he basically do the traction of the tongue and do suction for better field visualization. Another recent advance is hypoglossal nerve stimulation. If the main cause of obstructive sleep apnea is hypotonia of the genioglossus muscle, then this is a very upcoming thing, but still not available in India. The 2 devices which are available are Inspired and the Apnex. What the basic principle is that it has sensory lead, which is placed in between in the chest between the internal intercostal muscle and external costal muscle, and it gives us signal to the generator, which is placed in either in the chest or the supraclavicular region, which cause stimulation of the which gives signal to the stimulation leads, which stimulate the hypoglossal nerve. So that with each respiration, the hypoglossal nerve is stimulated and the genioglossus contract and opens the airway. So it's a very dynamic kind of implant. Now, after all these procedures, how will you evaluate the success? The success can be evaluated. Historically, it was either the 50% reduction in AHI or the AHI is made less than 20%, 20 per hour. Then you call these procedures as a success. But we all know this is only the respiratory part of the problem. Patient with OSA has multiple problems, and so new parameters are being proposed by Pang and Rottenberg, in which they have given 9 criteria for the various quality of life measures. So and they said that if a patient improves in any of these criteria, we should consider that thing as a success. So it can be remembered by the acronym SLEEP goal. The SLEEP goal, whether snoring is reduced, the latency of the sleep onset improves, upwards sleepiness scale, patient get better on ESS, and various other like oxygenation improves, AHI improves, and the life score, quality of life improves, the pressure improves of the patient. Now, a word about the OSA in children. In children, it is a very serious disease, and the criteria are more stringent than that of adult. The AHI classification says that mild is if AHI is between 1 and 5, Moderate disease is if patient is having 5 to 10 apneas per hour, and severe disease if it is more than 10 counts. So in apnea, measuring apnea also, in adult it is 10 seconds, but in patient, in children, it is time of either 10 seconds or 2 breaths, whichever is lower. The main cause are adenoids, tonsil, obesity, craniofacial anomaly, and hereditary muscle dystonia. And similarly, the main treatment is CPAP or adenotonsillectomy and weight reduction. So in summary, basically, I told you various aspects of obstructive sleep apnea. I told you that you should be having a thought process in your mind when the patient comes to you, and you should be able to comprehensively evaluate that patient. Simultaneously, you should have a thought process according to the patient factor or disease factor or the surgeon's factor, what all things you can offer to patient to improve his quality of life. I welcome any question for this presentation, and thank you. Ma'am, you have to unmute yourself.
Yeah, yeah. So thank you, Shalabh. That was an extremely comprehensive and really a good talk, and I'm sure the participants would have benefited. They would have recapitulated whatever they would have read before about obstructive sleep apnea. And any questions are welcome. We had a good number of participants. And obstructive sleep apnea, initially when I was doing my MS, at that time, in fact, my thesis was on obstructive sleep apnea in children. And we did adenotonsillectomy as the therapy. And we had the sleep lab at Safdarjung under the pulmonary people. Dr. J.C. Suri was there, and he had a polysomnography lab. And at that time, uvulopalato-pharyngoplasty came up, and but at that time it was just kind of coming up, the evaluation and those things, cephalometry, and those things were coming up. Now I think they have specialized centers for obstructive sleep apnea surgery. And somehow during the course of events, the surgeries became less, and more of CPAP was propagated, because surgery is a difficult proposition, and giving anesthesia, you need competent anesthetist. The patient has to come out of the anesthesia with a nasopharyngeal airway and awake, extubation, those things were there. So didn't get much experience, but now there are specialized centers of obstructive sleep apnea surgeries, and people are doing it as a special skill. They are developing as a special skill.
Future
So
is bright for the budding surgeons.
yes, whoever has an interest in this area, because and if you have a good maybe a maxillofacial colleague with you, and you can do it together, because the advancement techniques and some mandibular advancement and those things, if you have a maxillofacial friend, then I think you can do it. Must be very gratifying, because it is a really big problem. So
Ma'am, there are certain questions which are appearing on my screen.
okay,
One says that what are the exercise for oropharyngeal musculature? So this
yeah,
basically these exercises are beyond the scope of this presentation, and you can search it by the term myofascial therapy. Myofascial therapy for exercise. What it does is basically it tells you various sets of exercise for the lips, for the tongue, for cheek, and for the palate. And there are various sets of exercise which a person needs to do on a daily basis to develop a better coordination between the intrapharyngeal muscles. Hope that will help. Another question is difference between CPAP and BiPAP. Yeah, CPAP is a continuous positive airway pressure, whereas the BiPAP machine gives two level of pressure, once for the inspiration and once for the expiration. So the amount of expiratory pressure is bit low. The pressure which should be kept is between 4 centimeter of water to 16 centimeter of water. But using BiPAP is better, but it requires lots of titration. So as you go advance with the technology, then comes the problems also. Another question is, sir, what are the exercise for oropharyngeal musculature that I told you? Sir, what is the level of bispectral index to be maintained? It should never go down beyond 50. You can keep it, the ideal is around 60, but you can keep it between 50 to 70. Velopharyngeal insufficiency can occur due to UPP. Can it lead to nasal regurgitation? Definitely, because of velopharyngeal insufficiency, a patient presents with the nasal regurgitation only. So the word of caution is basically you have to see a pharyngeal dimple in the soft palate. That is the amount of soft palate you require to maintain the velopharyngeal sufficiency, velopharyngeal wall. If you don't breach that soft palate dimple and you take a safe margin of 5 millimeter more, and beyond that you can cut whatever you want to cut. So that will not cause velopharyngeal insufficiency. Another question is, do we get swallowing problem in radio frequency ablation of tongue? Yes, most of the procedure, in fact, the tongue procedure and the palate procedure, all procedures have dysphagia as a prominent problem. In the palate procedure and the tongue procedure, the main side effects are dysphagia, foreign body sensation, bleeding, and sometimes temporary velopharyngeal insufficiency, and along with the disturbed taste and other small problems. But most of the problems get dissolved themselves within 3 months of time. But obviously, this is one of the most nuisance problem, and it keeps on troubling you. Foreign body sensation.
Yeah.
Do we get swallowing problem? Please explain the hypoglossal nerve stimulation in recent advances. In the hypoglossal nerve stimulation, basically there are one stimulation lead which is kept collared around the hypoglossal nerve. It has 6 channels, and basically it is stimulated one by one, so that nerve do not get tired. And it has one sensory leads which is placed in the chest between the intercostal muscle. They will tell you the various phase of respiration, whether you are in inspiration or expiration. And then it is a pulse generator. So during inspiration, they gives a sensation to the pulse generator generate a pulse and stimulate the hypoglossal nerve. And just before inspiration, hypoglossal nerve gets stimulated and it causes contraction of genioglossus, and genioglossus comes out. And so that the posterior airspace is increased.
So this is one new thing that I learned today, the hypoglossal nerve stimulation. I was not aware of this recent advance. Yeah, thank you, Shalabh.
Thank you. There are lots of work is going on obstructive sleep apnea, and they have divided the sleep apnea into 4 phenotypes. One is in which the airway collapse is the main problem. Another is in which there is a hypotonia of the genioglossus. Third is in which the arousal limit is basically less. So they give hypnotics to improve their sleep. And the third is when there's a problem with the central nervous system in which the patient has high loop gain. So such patients are treated with acetylzolamides and diuretics.
Yeah, so basically, you need a very good detailed workup, the phenotypic classification that you said, and also at the about the level of obstruction, whether the obstruction is at the level of the tongue or at the palate, or maybe the nose is contributing most to the resistance. So the if you know the level of obstruction well, then you can treat that part, because otherwise the snoring and the sleep apnea problem will recur and you would have subjected the patient to some surgery and with no benefit. So that is very important to find out the exact level of obstruction. So I think we should stop here. And I'll once again thank you, Shalabh, for a very nice presentation.
Thank you,
And
Mani.
thank you so much. Mr. Navneet, we will close it.